All right, next up is someone who needs no introduction, really, Dr. Michael Wang. It's a real honor to have him here as a keynote speaker. He's nationally and internationally recognized, as we all know. He was the president of SUNS. He's been the chair of the spine section and editor-in-chief of the Journal of Neurosurgery and multiple editorial boards, 600 papers, H-index through the roof. Every award you can possibly imagine, and every position in neurosurgery. He's done a wonderful job in just being involved in organized neurosurgery. And it's a real pleasure and honor to have Mike Wang here give us the keynote speaker, to give us a keynote speech. And he's going to talk about reflections in minimally invasive spine. Welcome, Mike.
Thank you, Dean. Such a pleasure and honor to be here. Dean and I have known each other since college. I think I agree with Dean on almost everything, only he went to Berkeley. I went to Stanford, so I think we're like adversaries in that way. But other than that, we've known each other for a very, very long time, and Columbia is so fortunate to have him. I have to say, I did not pick this title. I don't know if one of the organizers picked it, and I think, Fred, yours is also called Reflections of, and I think I feel like it's kind of aging me a bit. I feel like I'm still sort of trying to figure this out. And I will say that I'm not going to talk at all about lateral surgery. I think Dr. Andrew Chan, and Dr. Chow will be speaking about lateral surgery, which is an entire world of surgery, which they're going to cover much better than I ever could. But let me see a show of hands. How many people are actually not working in New York City or the immediate area? Okay, you guys are from outside of this. Where are you guys from? Paris? Chicago? Columbia, okay, big cities, right? Everybody's from big city, okay. America's such a big, beautiful country. It's like all of Europe, right? So Paul McCormick and I were talking about, because I've known Paul since I interviewed here for residency in 1995, and I have immense respect for this place, about, what does it matter what geography you're in or what the practice location is when you start and when you build your career. And I think that has a lot of bearing. I had my first half of my career at USC in Los Angeles, second half in Miami. That has a big impact on how things develop in your practice and your expertise. But let me just say just a word about Columbia. I was not accepted to medical school here, college, or residency. It's too high-profile a place. But I was lucky enough at USC that there was a special connection, all the Columbia faculty know this, between USC and Columbia, partly due to Micah Puzzo, partly due to Ben Stein, the great Ben Stein. And I've always had a great deal of envy in my heart. And so when I see these great faculty members here, I think to myself, like you're in a special place here. So my hat's off to you. But my talk will take a slight turn in terms of what spine is all about. And I think it's always important to have a sense of context. And not everybody here is a professional spine surgeon. I consider myself a professional spine surgeon. What that means is my life is committed to what I call Church of Spine. And what that means is that I believe and eat and breathe and drink spine all day long. And I aspire to be the best spine caregiver I can, whatever that means, although I fail regularly. So a little bit about the zeitgeist and the environmental context that we're facing. And a lot of people like to talk about evolution, right? So I see a big band of age. Some people look like they're just maybe out of college or in college, and some folks are much older on the other end of the spectrum. And I think that we always talk about evolution. But as Dr. Chan said, the flip side of evolution is something called obsolescence, right? And that's a very, very dangerous thing for a neurosurgeon to talk about after you've invested 32 years into a career, and you're making a lot of money, and you're doing a lot of great things. And what we do is super high risk. It is very, very hard to change what you do because you're dug in. And I look at the tree of a man. Remember, we were in Africa. Some of the SUNS members, I think all the Columbia folks are SUNS members. Sean Levine's back there at the origin of man in South Africa, talking about like all these Homo species. And some of them led to dead ends in a way, right? So we're Homo sapiens, we're here, and what elements of surgery can we say are going to end up as dead ends? And this is a topic of great conversation and excitement, right? And fear, right? But here's some trends. The trends are clear. We are in an ever-aging society that has higher demands in a lower reimbursement environment with higher regulation. Any first world country faces this rubric: China, Japan, France, United States, Colombia will after they modernize, right? So this is the issue here that we're facing. Now, spine is about treating everybody because 95% of American adults will have a spine problem. I'm not saying they need surgery. That means everybody can be your patient. I treated all my neighbors, operate on none of them, but they've come to me for help, right? So spine gives you that ability, and it's very, very powerful because we have an impact on society writ large. So why do people have a dissatisfaction with us as spine providers, or let's just say healthcare providers? And I'm sure this will resonate for folks on this campus. This is a slide of a very important economic concept called Baumol's cost disease. What it means is that if you look at anything that's being done, certainly here in Manhattan, they look for greater efficiency, greater efficacy, greater safety, lower cost, higher throughput in every single industry, like guess what? Apple. 17's out. I got a 13. This is gone. This is not working well anymore. But there are two arenas where that doesn't play: higher education and healthcare. So when we talk to people outside of healthcare, they say, well, wait a minute. You're providing this care. Is it better? Is it faster? Is it safer? Is it cheaper? And our answer is, well, no. Well, you understand, like, we're neurosurgeons. Like, this is really hard stuff we do. So if I go to the Mike Wang of today, and I go back in time when I was Sean Levine's junior resident, and I think about when I finished training, you could say that maybe I do about 700 spine cases a year. Maybe that's 2.5 times when I started. So I'm about 2.5 times better, maybe, than when I was starting in 25 years. That's simply not acceptable. The world, the giant buildings you see over there, look upon us and they say, you guys aren't doing well enough. Now, I know that this is not so simple, right? But if you take a simple equation like Moore's Law and you say, what is the computing power of an iPad? Right? You can go to Walmart, get an iPad for $140 now. That computing power going back in time can be in the hundreds of trillions of dollars in value, right? Now, I'm not saying healthcare is the same thing. That's not what I'm saying. But I'm saying that most physicians, and I'm speaking more to the younger crowd, don't understand that the rest of the world looks at us and says, we need to get better faster. So this is what keeps me up at night. I think about the existential threats to us, because what we do as spine surgeons is critical in the right patients. We help people immensely. So if we cannot provide that care, then there's a big problem, right? The biggest problem in the third world in terms of healthcare is no access to surgery now. It's not about the vaccines and antibiotics anymore. It is important, but surgery is what they need, as we all know, in these countries. Now, in the US, what are we talking about? Well, people can get surgery, but there's a cost and there's a demand. So what's going to happen to us as our neurosurgical procedures are so expensive? And I think about T-Rex. I mean, I see T-Rexes everywhere in the room. People who are the apex predators in their field right now. It's something to be very proud of until the asteroid hits, or the diarrhea, or the change in climate, or whatever it is that wiped off the megafauna from this planet. So I think about spine surgery from a different perspective. I want to be that little furry mammal that can survive these things. And it's not always that impressive. It's not always like, ooh, look at that. But it is important for survival and adaptability. So let's get into surgery. So I'm going to talk a little bit about one of our projects at University of Miami, which has to do with TLIF, which is a common procedure that is used to decompress, fuse, and treat the spine. It is the most versatile procedure we have. Okay, in other words, if you had only one arrow in your quiver for thoracolumbar, it would be TLIF for sure. If you said, I just have one weapon to use to combat spine disease. Now, there's a lot of things you can do. You can do an open TLIF, you can do MIS TLIF, and MIS TLIF was a huge revolution, happened about 20 years ago, and here's a forest plot looking at reduced pain. Of course, MIS surgery has less pain. We don't need to belabor that point. Earlier normalization of life, very clear that happens. Infection, we published this data, a lot less infection. Infection's a big problem in spine surgery. Lower rates of CSF leakage. Dr. Mandigo will have to do less recovery and get less calls from us because there are fewer CSF leaks because you're exposing less of the spine, and less narcotic consumption. All of these are important from a societal perspective in terms of what we do for our patients. Now, I'm going to take a little detour here and talk about what a privilege it is to be a professor in a university. Okay, because we like to complain about that. Sean and I were grousing about it last night over drinks. But we are very lucky because in 2010, a young pre-residency fellow came to me and said, Dr. Wang, his name's Karthik Madhavan, Dr. Wang, have you heard about ERAS? I'm like, you mean the application process for residency? He goes, no, enhanced recovery after surgery. I said, no, He goes, well, you should look it up. You should look at this stuff, ERAS. Now, everybody's heard of ERAS in this room now, but I can tell you in 2011 at NAS, we had a symposium with a room with 1,000 people, and I asked, Dan Resnick and I asked, anybody heard of ERAS? Not a single person could raise their hand. Now your hospitals are calling, where's your ERAS program? Where's the ERAS program? So there's an old saying for the young people. If you really want to excel, there's 3 ways to do it, okay? You can be the smartest, which is pretty damn hard in this room. You can be first, or you can cheat. Now, I'm not going to cheat, and I would never claim to be the smartest, so I'm going to be first. So ERAS is a very important concept. We were the first to build a successful spine ERAS program in the world, and it has to do with all these features about the journey, fast tracking, and iterative improvement, quality assurance, and quality improvement projects. Again, we could spend days talking about ERAS, and there are conferences for this. This is colorectal ERAS. I'm not going to get into it. It gets very complicated. Colorectal was the first area where ERAS mattered. This happened to occur right around the nexus of the time when the Affordable Care Act was passed in Obama 2, I think it was, right? And there was the call for something very important that they were announcing, which was spine bundling. Spine bundling meant the end of spine surgery because it meant that you would have to provide all costs covered, all services covered for 30 to 90 days under a bundle of a certain amount of money, which is a pittance of an amount that you spend today, right? So we knew that we had to get to a new way of approaching this before the Affordable Care Act was going to put the sword of Damocles on our neck, okay? Now, that never happened because Trump won, but this is not a political statement because the Republicans and Democrats both want to pay us less, everybody in this room. So the question is, what is MIS, right? So you heard Dr. Chan talk about this a bit. Is tubular surgery MIS surgery? In other words, is an MIS TLIF done through a tube MIS? Well, let's ask the salient question, which is what size tube? Now, I would proffer that in the United States of America, the average size of a tube for an MIS TLIF is 26 millimeters. And that's why the open surgeons look at the MIS surgeons and say, that's not very MIS, is it? There is no need and no value add here. And all the residents know sometimes your MIS TLIFs stay longer than your open TLIFs. Can't figure that out, right? How could it be MIS if that's the case, right? So if you just do some real quick math, I had one of my kids do this when they were still in high school, there's a giant difference between using a 16 millimeter tube or a 22 millimeter tube, for example. It's not just something on your back table. The impact to the patient is very different. So I went into a very cataclysmic state of mind, existential, because here I had been for about 14 years or 10 years talking about MIS, okay? And I was like, wow, are we doing the right thing? One of the other great privileges we get is to communicate with each other and travel the world. This is an endoscopic users meeting in China. 1,000 users of endoscopy. Users, not like interest people. These people have endoscopic surgery. They only do endoscopic surgery. That is their sole role. So I said, I'm going to learn some endoscopic surgery. I'm going to start to get good at this. It's going to be the last thing I learn, right, before I'm too old to learn anything new. And so endoscopic surgery is essentially working through a 6 millimeter port to do the same job, hopefully, that you could do with a tube or an open surgery, right? So 6 millimeters is very, very different, and we can spend days talking about this. And through this, we've had the opportunity to write a lot, which is another great thing about being a professor, and talk about different ways of doing things, which is what you really need to do so Fred Barker can publish your articles and you can be promoted to the associate or full professor level, right? But we got very deep into this concept of how do we access the spine without opening the body up, without opening people fully and accessing through Camden's triangle. Now, I don't know, Guy, how many triangles you guys have in the brain, but there's a ton of them. We got one in the spine, it's Camden's triangle. And we went very deep into this concept of looking into the triangle and figuring out how to access the spine, what were the ways of enlarging and not enlarging the triangle, and getting to this inner body approach. How do you take the disc out? How do you fuse the spine? Most endoscopists focus largely on decompression. I'm very focused on this. But I recognized early that the real issue is fusion. We needed to get to fusion, right? So we started to develop principles of how do we percutaneously, endoscopically fuse people without general anesthesia. Sorry. So this just shows, there's a lot of pictures of old papers and stuff like that, right? So we used what's called a 1B endoscopic access, which we categorized in terms of what we would be doing to get into the disc space to do a fusion. And we built upon this foundation our Awake MIS lumbar fusion program. This is our ERAS program. So this is all happening, again, right before the Affordable Care Act. And I'll get back to that. So what is this built out of? It's built out of 6 pillars. The first, of course, is endoscopy, right? That's very important, so you don't have to open the person up. Second is not having to put the person to sleep. Third is percutaneous screws. You heard Dr. Chan talk about that. Fourth is Exparel, which is liposomal bupivacaine, which gives analgesia, inner body fusion, and biologics. These are the core technological tenets of this, allowing us to do surgery extremely efficiently, extremely efficiently. Now, I would tell you that I live in God's waiting room, okay? In Miami, when it hits 65 degrees, most of the people in this room, if we were in South Florida, would have scarves and earmuffs on. These are the people that cannot tolerate 65 degrees of weather, 65 degrees as weather, and they would complain. These are the weakest, oldest, most fragile human beings in the country, okay? All you have to do is go to Florida for a little bit and see. So we said, we're gonna fix these people. So this is the first case we ever did in 2013. You can see I'm talking to this patient. He's the former dean of FAU Business School, so this is not a rat lab. We are doing, sorry, some people do this stuff and they're just like, it's just patients we operate on. All these patients are special, they're important, they're human beings, they're fathers, they're mothers, they're brothers, they're sisters, they're friends. And here we are working endoscopically. This is pretty routine, doing the endoscopic approach, cleaning out the disc and all that. And we're not gonna stop there. We're gonna go on to do a fusion. We're gonna go on to do a formal fusion where we take the whole disc out, we replace it with a cage, we put in percutaneous screws. We do all of this while the patient's not intubated, okay? And this is the project we wanted to build upon. So this just shows a patient coming out of, I'm sorry, I hope the movie's run. We had a little trouble earlier. This is a patient 40 minutes after surgery. Oh, she's, okay. Anyhow, she's walking around the recovery room. And we've published on this extensively. Again, if you want to go deep into this, we can go deep into how we sedate patients, how we do the anesthesia side, right? And people say, well, why do you do this without general anesthesia? It doesn't make any sense to me. Like, it sounds stupid, right? They can hear everything you say, right? Well, okay, it's the most sensitive neuromonitoring. The dorsal root ganglion is very close. The one structure at risk is a DRG. You have reduced effects of cognition. You have reduced problems with homeostasis, right? So this shows kind of what it looks like. We start the surgery, patient gives us a thumbs up. We like to have patients go through this. There's no spinal block here, okay? We're not doing a spinal because we want to be able to monitor them. We do this because my average patient's 73, okay? The average. So I operate on, I mean, if I were to give you the numbers, the oldest person I operated on this week was 92, okay? Frequently will go much higher than that. And this is well known now. This is from the Wall Street Journal. People know, people actually ask the question now, what's gonna happen after my surgery? Am I gonna have a cloudy memory? Am I gonna be able to go back to my job? And it's a real thing. We just look at the x-rays and go, well, look, it looks perfect. And then the patient says, but I'm not the same person that I used to be anymore, right? This is an example. This is early on, 86-year-old patient with a cardiac EF of 11%. Now, I don't think there's any anesthesiologists here, but my suspicion is that an EF of 11% is a no-fly zone, okay? But we're doing surgery on him for a grade 2 spondy. You can see he's got pacer pads on. They're thinking maybe they're gonna have to shock him. And he has his surgery corrected. It takes about 45 minutes to do this. Fewer physiologic derangements, right? You think about all of the effects on the patient. When I was a medical student at Stanford, did an anesthesia rotation, this attending told me, Mike, I'm gonna let you intubate this patient with a laryngoscope. But when you do it, the feeling the patient's gonna have is like an elephant stepping on their chest. I'm like, what? He goes, yeah, it's just like flying a plane. It's takeoff and landing, cardiac stress, pulmonary stress, thermoregulation, right? Urinary retention, very common problem. We use no Foley catheter, right? Arterial lines, do they put in arterial lines for everything here at Columbia? Probably, right? This is our arterial line complication, right? And potentially, but I gotta be careful about this, expanding the population of people you treat. This is not a license to do unindicated surgery. This is a license to be able to get away with surgery successfully in someone who could be denied care because other folks said they were too sick. And now it's being recognized that surgery, even on people who are very old, can be highly beneficial, that maybe we should reconsider ageism in terms of our practices, right? How about fat people, right? How about people who are overweight, right? Are they unable to undergo spine surgery? Well, let me show you. This is an executive, actually came from Connecticut, flew down, 425 pounds, BMI of 53. Now, nowadays, we would put this person on semaglutide, but this is a person who is not intelligent or well-resourced. Nobody's gonna touch him. We do surgery, lateral position, no general anesthesia, right? Pre and post-op pain drawings, right? This is what it gives you the ability to do, right? And it's not always better, right? So let me talk briefly about the outcomes, okay? So to get good outcomes, you have to do good surgery, right? Good surgery means that you actually decompress the nerves, you can realign, you can lift, you can correct spondies, you can prepare the end plates properly, right? And then you can see the effects of indirect decompression. Now just look at this case. This shows you a classic Miami case. In a lot of people's hands, that's a, I don't know, T10 to pelvis? I don't know. It's a lot of disease levels, but really 4-5 spondy level is the source of the problem. And there you see the indirect decompression after fusion, Wolff's Law in play, patient's great. This is a kind of case, exactly. We're being picky. We're being very, very selective about what we do to people because our patients are indeed very, very sick, right? So we've done this. We're going on almost 500 cases now. Fred just published our data on 400 cases. The key to the surgery, as Dr. Mandigo said at the beginning, is the indications. All of these people need to have something fixed, right? They're not having it fixed because it's easier. They need to have surgery. And most of them have a spondylolisthesis, which is the best indication for treatment in just about any kind of spine disorder. There are problems, right? As I told you before, dorsal root ganglion, right? That is the topic at risk. There's really not much else to consider. The DRG is the singular driver in terms of what happens to these people, and I'll get back to that as well and what I really mean by that. But let's talk a little bit about that stuff with Baumol's-Koss disease, okay? Because that really is the driver of this. I don't get paid any more to do this surgery than an open TLIF or MIS TLIF or whatever, okay? So when I first came out of residency, I was shown this slide. And this is the exact slide. It's been different colors, and we've seen it duplicated now. A lot of people talk about this cost of surgery, right? And the cost of surgery is the effect of, not the financial cost, the effect. It's social, it's psychological, it's physiological, right? I do enough surgery that I tell you I probably create 4 divorces a year. Okay, people are like, what? What are you talking about? What's happening at the Wang clinic, right? I'm telling you that the stress of surgery is so significant that people change. Everybody knows the case where someone came in and like, doc, you're gonna fix me, I'm gonna go back to work. And on post-op day 90, they say, you know, doc, here's my disability paperwork, I changed my mind. What happened? Well, something happened. They didn't lie to you. Something about that process changed the way the person interacted with the fabric of society. Okay, and there's a lot of reasons why that happens. So this is a slide I showed all the time in 2002. I'm like, yeah, that's what people are afraid of. People are afraid of that blue area. So I said, I'm going to reduce that cost. So I started talking about, well, we're going to launch this ERAS program. We're going to bring that cost curve down. And again, this is not necessarily financial. And we are going to make it like background noise. That's what we're going to do. So now let me show you a slide from 2021. John Yoon, one of our former fellows who went from Penn and now he's at UCSF, helped us start a company. We track people's activity. We do it live. It's hourly. It's like based on your phone technology. It's not a watch. It's based on your phone. And we can track exactly what people are doing every hour of every day, even going backwards. So the red curve and the blue curve are what we call the fingerprint, the phenotype of recovery of a patient who has surgery at 0 days, right in the middle there. The red is an endoscopic fusion. The blue is a microdisc. Now, this is a very dangerous slide to show. It's like giving a child a bazooka. It's saying that we can get away with doing a fusion in someone, but have the impact be something not like a fusion anymore. Now, the flip side is this is a very positive thing because it changes the ability to get people through a very, very difficult process. This is me against me, narcotic usage in standard MIS TLIF in blue, awake TLIF in orange, and we all know that there's a narcotic crisis. We publish our cost data. Cost data is almost impossible to get. The only other person I know who's published true cost, not imputed, true cost data is Sig Bervin at UCSF, and he got in big trouble for that, right, Dean? He published it, right? We published in Miami because the CFO of the hospital was leaving. And I said, hey, can I get some of my data? He goes, yeah, I really can't. I'm like, no, come on. Like, I've been really good to you. He goes, okay, fine, I'll give you your data. And so this is the data. What it shows, and I know it doesn't print well, is if you look at our endoscopic fusion, total cost of event is $19,000 minus pro fees. MIS TLIF is $22,000. Now, I promised I would talk about bundling. Does anybody know, and please not, this side of the room is like the senior doctors, this side of the room is like trainees. I'll give $100. To anybody who can tell me what they think that number, that dollar number is going to be bundled at, and I'll give you $100 if you can get it within $3,000. Okay, anybody on this side of the room? These are the trainees. Come on, somebody raise it. Nina, come on, you lose nothing. Take a guess. No. Good guess. Good guess. Anybody else? $5,200 for a surgery for TLIF. Anybody else? Pete Angevine squirming now. He's like, these guys, we gotta have more journal club. This is very important. It's true for hips and knees too, right? They're bundling at about $25,000. So if you can get your costs under $25,000, you're in business. If your costs are over $25,000, if that's the number, you're out of business because you're losing money on every single case you do. No hospital is going to support that. Now, I'm not a proponent of bundling or not bundling, but I'm just telling you, this is what keeps me up at night. This is the asteroid coming to strike your hospital to say you are out of business, okay? Now, you may not care and say, look, I don't really care about any of that. Like, that's the hospital's problem. I'm an employee, right? Okay, well, let me tell you something you do care about. This is about time. Time is the most valuable thing that everybody in this room has. Time. So thank you for taking the time to listen to me. I know every minute of your day is valuable. These are two of my cases selected at random. On the left is a MIS TLIF by me. It's Mike Wang. On the right is an awake TLIF, Mike Wang. This is Mike Wang against Mike Wang. This is not me against somebody else, okay? So here we are in the room, 7:25. This is off Epic, okay? Here we are in the room at 7:25, okay? Same time, because we're pretty good at that. Here we are, prep start. Prep start is when anesthesia relinquishes care over to the surgeon, okay? They document that for sure. Here we are, 7:40 and 7:32, so, I'm sorry, 7:40 and, yeah. So I've saved 17 minutes at this point in the day. Here we are at procedure start. This is when you cut skin, okay? 8 o'clock versus 7:38, so now we're 22 minutes. So I'm 22 minutes ahead of myself at the beginning of cutting skin. Now you may say, well, who cares, 22 minutes? Okay, I'm gonna keep going here. Now the procedure, 10:56, 8:30. You gotta wake the patient up, get him out of the room. 11:06, that's pretty fast. That's 10 minutes out of the room. That's pretty darn good. 8:35, I'm 151 minutes ahead of myself at the conclusion of the first surgery of the day. That's 2.5 hours. Okay, now, if you save 151 minutes per case, and it's not all about time, it's not about rushing. I know you're recording me, so patients will go, well, it's not about rushing. It's not about rushing. It's about time under anesthesia, right? That's also, if you did 100 of these, 15,100 minutes, 251 hours, 10.5 24-hour days. So I have the ESMIS fellows down in Miami right now. They're traveling around the country, and they're going to see me operate on 7 cases, 2 front backs tomorrow. And everybody comes in. The fellows were texting me last night. They don't believe it. I'm like, yeah, we're going to finish essentially 9 cases tomorrow by dinner time, 5 o'clock. And they say, well, how is that possible? What you're doing is impossible. It's not impossible. This is how I can travel to come meet you nice people. 10.5, 24-hour days extra just by doing this. This is just one facet of what we do, right? But what if you remain unconvinced, okay? What if you say, well, I don't care about time or money or any of that? Okay, well, let's go back a little bit. I want to wind back time because everybody's forgotten this. 2020, spring of 2020. I knew it was coming because Taiwan shut their doors on New Year's Eve of 2019, 2020. That's the COVID pandemic. And I remember that time when nobody was allowed to do anything. And you should be afraid that maybe you're just like, you need to just hang it up because this is over, right? You guys remember that time? Everybody wants to forget it. It's like, yeah, that's a past. This was very scary. It's the first time we saw doctors get their salaries docked, like at Mayo Clinic and Cleveland Clinic, and nurses' salaries went up. And it was really a reorganization of the healthcare system, which we're still sorting through now. These are the slides from the President of the United States, who happened to be Trump at the time, not a political statement. And this is about opening America up. This is 2020. Phase 1. And I'll read it to you. Elective surgery may resume as appropriate as an outpatient. What this means is if you can do your surgeries as an outpatient, you're in business. If you can't, you're out of business for now. Now, you may not care because doctors are so secure until they're not. This was a very important time for me too because it was the proving ground, right? People were so afraid to come to the hospital. We were worried about protracted recession. We're not done with this yet, right? single payer, this might actually be the fuse that ignites all of that, right? We're not done with that. Privately insured patients are shrinking, right? A lot of things happen, right? Tremendous economic pressure, right? And what are the long-lasting effects? And I'll never forget, because during this time, minimally invasive really matter. Could you really do an MIS surgery? Anybody can say they do MIS. Okay, so we talked about this, right? We talked about what MIS is, right? Now the difference matter. Will the patient have to stay in-house? Will you need an ICU? Will you need rehab? So at that time, this is May of 2020, I was at home more, and I got a call. I was looking at Epic, and there was a lady who sends a message to me, a British lady. I'm going to kill myself. I'm like, oh, that's kind of a big statement. I should take that seriously. So I call her up. What's going on, ma'am? She goes, when I saw you in February, I was getting through with epidurals. I can't walk anymore. I have 3 kids. And I know this lady. She's crying. I can't walk to the bathroom. My husband has to work. What's going on? I need to get fixed. I said, well, I'm sorry, ma'am. I don't know if you noticed, but there's a pandemic going on. There's no elective surgery. She goes, please, Dr. Wang, whatever you can do, anything you can do, can you do anything to help me? Everybody was at home relaxing, right? So cush in your pajamas until you have no job. So I said, let me look into this. So I called the CEO of the hospital, and she goes, we're not doing elective surgery. I'm like, well, what if I don't need anesthesia? Do you remember that time when you were doing a case, and and this is kind of sexist, they'd send a young female CRNA in to intubate, double N95, and all the senior attending anesthesiologists sitting out the room like this, and they'd intubate, then you'd wait, 15 minutes? And I'm like, oh, you're safe now. It's going now. You remember that time? That should trigger something about your memory, because the CEO goes, can you do this surgery without anesthesia? I'm like, we do it without anesthesia, period. She goes, do you need to stay in a hospital? We don't have enough nurses. I'm like, no, she's going to go home. So we did the surgery, 40 minutes or so, 1-level TLIF. She went home. And then 3 days later, I get a call from the hospital CFO, because I'm always in trouble. And the hospital CFO goes, Mike, I got to talk to you. I'm like, oh, damn, what did I do now? He goes, you know that case you did the other day, 3 days ago? I'm like, yeah, I know. I got permission from the CEO. He goes, do more. And then we reopened our project, and we did a gazillion surgeries. All the other hospitals open, close, and we stayed open. Now, who knows, right, what's going to happen? Who knows what the next problem is going to be? I don't have all the answers. I'm just trying to tell you that I care about what's coming. And there's a lot of stuff coming. If you follow the news and watch carefully, a lot of stuff coming. A lot of things to think about. You got to be careful with these surgeries. You can break the end plates. You rely on indirect decompression. The dorsal root ganglion, I promise I'd get back to this. This is the one structure at risk. It is hard to get to in certain cases. The facet anatomy is critical. The disc anatomy is critical. Spondies are the best because the nerve root gets dragged forward. So that is the best case to avoid DRG problems. Sometimes you have to take a little facet. Obviously, taking the facet is easy when you do an open or mini open surgery. And if you have a DRG problem, people are not happy. That is not a happy patient. So DRG issues are the most important issue in this surgery. And I'll leave you with this because this is important. This is from Luis Pimenta. This is from our textbook on lateral surgery. Luis Pimenta, because he's so powerful and he's so important, he founded Invasive and then Alphatech basically. This is from him. In Brazil, when they started to do XLIF, they tried to use this posterolateral corridor. This is the only corridor you cannot go through. You cannot go through this. When they did that in Brazil, it was disastrous. That's when they invented the XLIF. So just something to understand about that. So we're not stopping there, right? We've been doing this for a while. We now have robotic TLIF that we do with the endoscope, right? We can do all of that. We can do these things using the robot. The robot's amazing because it doesn't have anthropomorphic constraints. Its hands can be tiny or gigantic. It can have 10 hands or 2 hands or 1.5 hands. It's not constrained the way we are. We've published on things like this using the robot with the endoscope to drill and do things that are exciting. There's a great, brilliant future for young surgeons out there. Augmented reality, we have augmented reality systems too. We have every tool and toy you want in spine in Miami because it's a giant spine center. But really, I want to get back to what Dr. Chan touched on and Dr. Angevine, because they touched on fundamental tenets. I'm just telling you about style, right? Deformity surgery is, in many ways, the future, right? And I think about cases like this. This is a for more minor deformity, right? But doing this 3-level, which we did, awake, endoscopic fusion in about 2 hours, right? Adding lordosis to patients, that's very critical, especially at 4-5-5-1. Getting that done by not having to open somebody up or do some crazy approach and keeping the costs down. The costs and expense are really, really critical, right? And I think this is where we're headed to the future, right? What if you could do the deformity surgery endoscopically? What if you could build modularized systems where you could do the surgery, let's say section the ALL with the endoscope, put in a cage? What if you could do it without general anesthesia? What if you could build upon modularized systems where you build a part of the surgery and you let the person rest, like Dr. Chan said, right? But do it in an even more protracted fashion. You do a little bit of surgery, 40 minutes a day. Next month you come back, like braces. We're going to do a little more surgery. And you gradually correct people's problems, because one of the big issues with those big surgeries is the abruptness of the surgery. You're making a giant change to someone who went through 30 years of change and evolved, and now you do it in 3 hours, right? That is very, very disruptive. So that's where I think the future truly is headed. But in the end, MIS, Dr. Chan's right, is the revolution. Patients really, really need this stuff. They're dying. We have an aging population. Access is going to be the issue as well as cost. So I do want to thank Columbia for inviting me. It's really a pleasure to be back here. It's an institution I was never worthy of, but thank you for your time and attention, and happy to take any questions if anybody has any.
Great talk. My questions for Dr. Wang. Any questions? So Mike, I'll start us off then. In terms of what you think about trying to develop awake surgery, I know people have tried it, and it's been very few people have actually replicated what you've done. How would you tell people, like, if I want to do this in my hospital, is it going to be easy? Is it going to be hard? Too many roadblocks? What are your thoughts in terms of doing this at another hospital?
Yeah, it's super hard. I mean, I had to go, just so you guys know the journey, I had to go to the dean of the medical school, and the dean called in the chair of anesthesia and said, "You're going to do this." Because what Dr. Wang's saying is right. It's like, I know you guys are dug in anesthesia. You want your 15-minute blocks. Check, 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 right? Sit there, read the New York Times or Wall Street Journal, whatever you do during your case. But we want to own the future. And so resistance is everywhere, right? Resistance is all you'll face. What is it? You want if you get arrows in your back, at least you're ahead of everybody else. I mean, the bottom line is that I'm not saying that everything I'm doing is right. What I'm saying is that if we just sit here and sit on our hands and go, we're going to do surgery the way they did 10 and 15 and 30 and 100 and 1,000 years ago, we'd be finding people's heads still. So I'm not saying that I have the answers, but I see some brilliant people in the room who are a lot younger than me, and they're going to have some big answers maybe when I have my surgery.